Hello friends, very good evening. I'm Dr. Priyashri Mukherjee and I'm back with the essential short topics in pediatric series, and this is my YouTube code. If you are going for a plus subscription on an academic platform, then you can use my code which can help you avail 10% discount. So that's a very good deal. I hope all of you all are safe and sound, and as our lockdown continues, but our spirit of studying continues as well, and nothing can stop us from learning more and more something new. So that's the benefit of Unacademy and Unacademy Plus platform, where we can share, distribute so much of information and gather so much of information that sitting at home itself, so perfect concept of studying during a lockdown. So let us just talk about the congenital rubella syndrome. Yesterday we had discussed about congenital toxoplasmosis, and I had discussed how to easily remember by the simple diagram of a cat, right? So today again I will have a simple trick for you all to remember about congenital rubella syndrome. Okay, so as you see, this is a very beautiful flashcard which is showing microcephaly, PDA and cataracts, right? So how to remember this basically? Okay, so first of all, let me tell you one thing. When we are talking about congenital rubella, okay, so this, from this R you can itself remember that it is a RNA virus. Okay, now let's come to this Bella. So we have a very beautiful mnemonic like Bella baby. Okay, Bella means beautiful. Okay, Bella baby. Of course, I have not discovered this type of studying. I mean, this is something that we have also learned. So I'll just share this with you all so that it will be easy for you. So Bella baby. So I'm going to draw a beautiful girl. Okay, because it's a beautiful baby with a small head. Okay, and the body is bigger as compared to the head, right? And then we have the hands and the legs. Okay, coming to the head, then we draw the eyes over here. Okay, and some blush on the cheeks because it's a Bella baby, right? And plus she's wearing a beautiful earrings, right? And with some hair at the end. Okay, now let's see the significance of this. So this is microcephaly. Okay, coming to the eyes, that means cataract, right? This hair I've drawn as E. Okay, so that itself means encephalitis. And coming to the blushes, it's the blueberry muffin spots, right? Okay, now these children often have cardiac defect. So they are beautiful girls with a heart drawn over here. So they have got either VSD or PS or a PDA. PDA is far more common, and they often wear a toga. Okay, toga is this type of a badge that often we wear, the models wear, right? So I'm just writing it as toga. Okay, so because what is this toga? Basically, toga is the family of the enveloped viruses that is causing rubella. Okay, so that is the toga family. So these are all the basic information that you can remember as far as rubella is concerned. So you see, in a simple image we have actually covered almost 70% of the conditions that we see in rubella. condition. So we saw that it's an RNA virus. Then we derived Bella baby from rubella. So we saw that the Bella baby is a beautiful girl who has got a small head and a proportionately large body. So there is a microcephaly. The eyes are showing cataract. There are blushes, which means there is blueberry muffin spots. The huge ears over here show that there is a sensory neural hearing defect, okay, or hearing loss. And then finally they have this cardiac anomalies, and with the toga, they belong to the toga virus family. The viruses belong to the toga virus family. Is that clear? So that makes it very simple. Hello Mulai, hello Dr. Abu, good to see you back, long time. So I hope you find this today's session interesting. We'll be talking about congenital rubella rubella syndrome. So this is just a small beginning mnemonic to remember things about rubella. So as I told you, rubella is also called as the German measles or the third day measles, right? And it is an RNA virus. So we already discussed that. Okay, now we have this MR and the MMR vaccinations, right? So MR vaccine we are giving at 9 months of age, and thereby at 15 months we are giving MMR vaccination. So from that we can say that rubella is a vaccine preventable disease, right? Now coming to the rubella per se, the infection. So it is just a mild self-limiting exanthematous disease, okay, where you can see the rashes mostly on the day 4th of the illness, okay, and they are typically sparing the face. They are first to involve the trunk, right, and then they spread peripherally to involve the other parts, the neck and the limbs, and the last to get involved is the face. Okay, so this is one typical pattern that you should remember about the rubella virus. Okay, now coming to the epidemiology. In the pre-vaccine area, the rubella appear to occur in the major epidemics every 6 to 9 years, and smaller peaks interspersed every 3 to 4 years, right? And most common age group were between the preschool and the school aged children. So that clears all these important points. Now coming to the next part, that is following introduction of the vaccine, the incidence has gone to below 99%. Like now the efficacy of the vaccine is so huge that it is 99% effective in preventing the condition. Okay, its major clinical significance is transplacental infection and causing congenital rubella syndrome, that now we know, and infection earlier in pregnancy has a higher probability of affected infects. Okay, this is quite opposite to what we saw in cases of toxo, where we saw that as the trimesters increases, that is the risk of having an infected fetus is max in the 3rd trimester, whereas here it is the 1st trimester. You can see this percentage wise. So here again the most important risk factor for severe congenital defect is the stage of the gestation. This holds true. Okay, now coming to this next portion, which is very important. This one, the risk for congenital defects has been estimated at 90% for maternal infections before 11 weeks of gestation. So this was an MCQ which directly I've picked up. Okay, now this is important for your sequential arrangement. Okay, so what is this basically? This is the risk factors of having an infected fetus. So during the 1st trimester, between 11th to 12 weeks, the chances are max, that is 33%. This decreases significantly during the 2nd trimester, that is at the beginning of the 2nd trimester, that is by 13 and 14 weeks, and by 15 to 16 weeks thereafter it is 24%. Okay, defects occurring after the 16th week are uncommon, that is later the stage of infection. Less common are the risk of having fetal infections and the congenital anomalies. I believe that makes it very clear. Okay, so this is an extremely important table, okay, where I don't want to mix up anything, but most of the things we have already discussed, right? Like the permanent manifestations we have already seen, that they have this hearing impairments or deafness. Mostly they have sensory neural hearing loss. The congenital heart defects, like we saw, Okay, then the eye defects, most commonly it is the cataract, right? We saw the picture of the cataract in the beginning of this session. The cloudy cornea, microphthalmos, pigmentary retinopathy, congenital glaucoma. They have microcephaly, and of course they can develop some sequelae of central nervous system, like as in mental and motor delay and autism. Okay, now coming to the transient manifestations, most of the things are common with the others, like there is hs-megaly, right? So hepatosplenomegaly is one very important feature, in addition to the lung manifestation, that is interstitial pneumonitis. The third most important is thrombocytopenia with the purpura or the petechiae, which we often attribute as blueberry muffin syndrome, right? Then next is the intrauterine growth retardation, adenopathy and meningoencephalitis, right? So out of this, I think 70% we have already seen in that diagram. Just which we didn't see was the hepatosplenomegaly and the interstitial pneumonitis, which you can remember easily, right? Okay, now coming to the clinical manifestation. So again, this is very important from sequential arrangement pattern of question. Okay, now coming to the sensory neural hearing loss, you can see the percentage, it is the max. Okay, so there are maximum chances of having sensory neural hearing loss. Then next to the list is the cataract and glaucoma. So you typically find a salt and pepper retinopathy. Okay, I'll show you the image later on. And then unilateral or bilateral cataracts can be another finding. Then similar to cataract and glaucoma, the chances of cardiac manifestations, malformation is also 20 to 50%. Then neurologic manifestation is 10 to 20%. Okay, now see this. This is the beautiful image of a blueberry muffin spot, right? You can see the cataract. The diagrams are clear. Can you all see this? I'll just flash this for some time so that you can have a good look at the diagram. This, along with hepatosplenomegaly, along with thrombocytopenia and presence of pneumonitis with an IOGR baby, should always give the suspicion of congenital rubella syndrome. Yes, Abu. Blueberry muffin spot is actually pathognomic. It is secondary to the thrombocytopenia, which causes petechiae and the purpura. Okay, rubella often has thrombocytopenia. Is that clear? See in this picture. So these are all important from image-based questions as well. Okay, now coming to the diagnosis. Many of the MCQs has been asked from this particular slide. You will realize it later. In fact, so many MCQs has been picked up from this particular section. Now, what is important over here? Okay, so we know that to confirm the congenital rubella syndrome, we have the immunologic, we have the serologic assays and the virus isolation per se. Now the first MCQ which is asked oftenly over here is from where can you take the samples for the virus isolation? The best sample that you can get for the virus isolation is the nasal secretion. Okay. Then less frequently from the throat, blood, urine and the CSF. So first on the list is the nasal secretion, although you can also get the samples from the throat, blood and urine and CSF, but less commonly. And infants with congenital rubella may excrete the virus for up to 1 year. So again this is important. Okay, what we saw in Toxo was you need to treat the case after diagnosis for at least 1 year. So that was the importance of 1 year in toxoplasmosis. Here the importance of 1 year is that they will keep on excreting the viruses for 1 year, and that is the reason why we need to treat the cases for 1 year. Okay, so this is how you need to remember. Now coming to the serological testing. Okay, so first I told you whenever there is acute infection, the best and the first marker is IgM antibodies, right? So the first is IgM capture assay. Okay, like when there is a recent postnatal or a congenital infection, right? Now coming to the next is serum IgM antibodies may be present for up to 1 year after birth, but the significance is more later on, later infancy. Significance of IgG titers are more, right? So the rising titers of IgG every month will signify that there has been a congenital infection and we need to treat it. Right. Now, diagnosis after 1 year of age is difficult to establish because they do not secrete the viruses anymore. Now, here, if you talk about the treatment, we don't have a typical therapy as we have in Toxo. So, we have spiramycin in Toxo, we have pyrimethamine in Toxo along with leucovorin. But here, we don't have that. Here the first thing is prevention is better than cure. So we would like to immunize in order to prevent all the young women from getting this particular infection. Second is a supportive care. So once this rubella syndrome or the congenital rubella syndrome has been established, there is no way out. We just have to provide supportive care, like as in a child who has got developed the cardiac manifestation needs cardiac treatment, sensory neural hearing loss, send them to audiologist, send them to the speech therapist. If neurological manifestations are there, autism is there, motor delay is there, send them to the neurologic evaluation, and so on and so forth. So ophthalmologist, pediatrician, cardiologist, audiologist, speech therapist, neurologist, all are in picture together for the supportive care of this of children with congenital rubella syndrome, plus in addition to parent education. Okay, now so you all know that there are this 2 doses of MMR these days, right? Okay, so now we were having this schedule. Okay, vaccination. Well, first we were giving at 12 to 15 months, and the second we were giving at 4 to 6 years. Okay, recently IIP has changed this protocol to 9 months, where we are giving the first shot of MR, which is having rubella, and the second is 15 to 18 months, where we are giving the second shot of MMR. Fair enough. So that's a new recent advance. Okay, now the second is children with congenital rubella syndrome may excrete the virus in the respiratory secretions up to 1 year of age. So contact precautions should be maintained from them. This is very important from MCQ point of view also. Contact precaution should be maintained until repeated cultures of urine and the pharyngeal secretions has been negative. So the most important thing that you would tell the parents that up to 1 year of age you have to have this contact precautions. Okay, so these are some basic things about the congenital rubella syndrome which you all are supposed to know. Okay, now let's solve some interesting MCQs. Mulai, I am taking these small topics daily at 7:30 p.m. I've tried to be very rigid with my timing so that most of you don't get confused. Okay, like yesterday I took Toxo, day before that I took nephrotic syndrome. So if you are a member of my Telegram channel, I can share you the links so that you all can sit and just watch the videos. Those are very useful videos. Okay, very good. So all of the following comprise classical triad of congenital rubella syndrome. Yes, except I need to add the word except over here. So most of you have given the correct answer. The answer is micropnathia. Very good. Okay, now let's solve this. True regarding congenital rubella syndrome are all except infant of congenital rubella syndrome can shed virus in the respiratory secretions up to 1 year of age. Risk of developing diabetes mellitus is considerable higher in congenital rubella syndrome. Cataract in congenital rubella syndrome is always bilateral, and risk for congenital defects is high when fetus is infected during the first trimester. Very good options, although lengthy option, but they are very good options. Okay. What about others? So Mulai and Tejendra have given the answer. Okay. So all of you are with the C option, which is absolutely correct. Okay. The cataract and CRS is not always bilateral. Fantastic. Okay. Now most common manifestation of congenital rubella syndrome is cataract, deafness, PDA and chorioretinitis. So if you see, there is cataract, there is deafness, there is PDA. Of course, there is we don't see chorioretinitis typically, but you can see that the question here is most common. So I want all of you to try this question. It's a very good question actually. What is most common? See, we need to be very particular when we get this particular thing as most common. Okay, so in this I'm getting a mixed picture. All of you have given separate answers, but the answer is the sensory neural hearing loss. It is the most common, top of the list. I had already given you top of the list is the hearing defect. See, I'll show you the slide again so that you get a permanent impact of that. See, right now you will never forget it. So the most common, that is top of the list, is the sensory neural hearing loss. Then comes the cardiac and the cataract and glaucoma have equal chances. So both are like 20 to 50%. So second on the list are these three, that is cardiac and glaucoma and cataract, and third on the list is the neurologic manifestations. Got it? So I believe you will never forget this. Okay, now let's solve this one. All of the following statements about congenital rubella syndrome are true except IgG persists for more than 6 months, IgM antibodies present at birth, most common anomalies are hearing and heart, increased risk of congenital malformation if infection occurs after 16 weeks. Read the options very carefully. They're very good options. Think and answer. First is IgG persists for more than 6 months. Second is IgM is present at birth. Third is hearing and heart are the common. Fourth is increased risk of congenital malformations if infection occur after 16 weeks. Wonderful. So all of you have come up with the answer of D, which is an absolutely correct option. In fact, after 16 weeks, there are less likely the risk of having congenital malformation decreases. In fact, the chances of having fetal infection only decreases per se. So that was very good. Okay, now quickly we'll just go through the cytomegalovirus. Cytomegalovirus is comparatively easy, so it doesn't have a real mnemonic like that, but with the images itself you can remember. So 90% of the infected infants have subclinical or chronic infection. Okay, so now this is important. Absolutely, you are correct, Malai. Very good. Okay, so 5% have minimal involvement and 5% have severe cytomegalovirus infection or the cytomegalovirus inclusion disease, right? So these are the typical manifestation. If you see, they are all similar to the previous ones, right? So nothing new. I didn't come up with any interesting mnemonic to remember this. You can just remember it as it is. So there will be one thing, that is a small child, a premature child. Again, HS megali is common, okay, right? Microcephaly is there, thrombocytopenia, intracranial calcification with a chorioretinitis, that is cottage cheese with ketchup, and sensory neural hearing loss. So these manifestations are mixture of what we see in toxo and rubella. Okay, so now we have this image. Okay, I'm coming in between the image. I'm just shifting my position. Just see carefully. The cottage cheese with ketchup type of chorioretinitis. You can see the normal fundus, right? And this is the next to this. Can you all see it? Just check this out now. I hope you can see it now. Can you see the diagram? Can you see the abnormal retina? Right? So this is the image, like it's just like sauce has been spread on a cottage cheese, right? The image right behind me, or rather next to me on this screen. Okay, so that is a very important thing. I've already uploaded a PDF of this lecture in Unacademy as a special session which I had taken last month. You can download the PDF if you're interested in the literature part. You'll get all the information, and plus the notes will help you in knowing and studying what is important and relevant. Okay, now coming to the diagnosis. So the virus isolation here also, the best is from the urine. Now here we don't have the nasal on the top of this list, just like rubella. Here we have urine, right? Then comes saliva, then bronchoalveolar washing, and the breast milk. Okay, now the diagnosis of congenital cytomegalovirus is best confirmed by the isolation of the virus per se from the urine. Okay, now the seroconversion or simultaneous detection of IgM and IgG antibodies with low avidity, right? So yesterday we saw what is avidity testing. If you want to know, you can just see yesterday's lecture. I've shared 2 slides. Avidity testing, just I'll brief about it. It is the affinity between the IgG antibodies with the viruses. Okay, so we measure the avidity, right? So you can see some interesting calcifications over here with in the cytomegalovirus infection. Can you see the small white lines over here with these white dots? These are the small intracranial calcifications that you often see. This is actually a CT scan of a 4-month-old child with congenital cytomegalovirus infection, right, which is showing many intraparenchymal calcifications, especially in the periventricular area. You can make out very well. Always remember this. Now with this you can compare the calcifications of the toxoplasmosis. Again, for that you'll have to visit my yesterday's lecture. I'll share the link of my yesterday's lecture also in the Telegram channel, so that you all know. Okay, and cortical abnormalities are seen in the right frontal cortex. Well, we can skip that for now, but definitely the intracranial calcifications are very classical over here. Now coming to the treatment, the best treatment over here is ganciclovir with immunoglobulin for all the life-threatening cytomegalovirus infections. Okay, oral. So now we have the replacements. We have oral ganciclovir and foscanates as well. Now, if there is a congenital infection, we have to give ganciclovir for 6 weeks to prevent any episodes of hearing loss. Right now, we have this induction therapy where the dosage, you may or may not remember the dosage. That's absolutely okay, but just broadly, if at all you are asked about the dosage, you should be knowing that it is given somewhere around 5 mg per kg per dose twice a day for 2 to 3 weeks as a induction therapy. Just remember that. And then following that, we have the maintenance therapy where the dose is almost half, which is again 5 mg per kg per day, which is a single dose. Now here we are not going to give 5 mg per kg in the morning and 5 mg per kg in the evening. So that's a single dose for 5 to 7 days in a week for 8 to 12 weeks. Okay, and of course when you are giving ganciclovir, we need to do a weekly assessment of the renal function parameters because it is a renotoxic drug. Therapy should be stopped the moment you document a low neutrophil count, that is below 500 per millimeter cube. Okay, neutropenia, or there has been a thrombocytopenia less than 25,000 per millimeter cube. So these are 2 things that you should remember. The first is this renal function test, and the second is a CBC, where again you will see 2 things, that is a neutropenia and thrombocytopenia. Okay, and remember this CMV is the most common cause of congenital infection in neonates. Right now, coming to the risk for the fetal infection, which is greater with maternal primary cytomegalovirus infection, and the incidence is almost 30%. Coming to the perinatal transmission is common via the genital tract secretions, most commonly during delivery and less commonly during the breast milk feeding. Okay, so cytomegalovirus as such is not a contraindication for breastfeeding. Please remember that. And cytomegalovirus is the most common cause of that we have already seen, right? So that actually finishes our today's session. That is, we saw again rubella and cytomegalovirus. If you like the session, I have already uploaded the PDF of the entire congenital infections. That includes herpes simplex, congenital varicella infection, and all the MCQs which has been asked till date on this particular topic on Unacademy special session. Last month I had taken it. You can attend the lecture. It's a 1 hour session. Of course, the portion which you have already attended, that much portion you can skip. That's the benefit. So no time was wasted. And secondly, you can download the PDF, and please read the literature which I have already given to you in the PDF. That's important because it has been made very meticulously, keeping in mind all the important MCQs that has been asked over it. Okay, so I end my session over here. It was indeed a very interesting, good session, interactive session. That's always like about all the students. You all are very interactive and really very good in answering the MCQs. I'll come tomorrow again at 7:30 where we'll discuss some cardiology, common topics in cardiology, like we'll discuss CCF. We have infective endocarditis to discuss. We have rheumatic fever to discuss. That will distribute between tomorrow and day after tomorrow. So 2 more sessions are going to be there for you all this month, and then again next month I'll come up with some more interesting sessions. Some specific YouTube sessions that you all want me to take, you can put it in the literature box, dialog box over here, the live chat box. I'll just share my Telegram link over here in case for those who all are new and we are meeting for the first time. It's t.me/Dr. Priyashri. So that's my Telegram channel. Do subscribe to my channel where I can just update you about my YouTube sessions. Yes, that's good for you, Mullai, so that you keep on knowing what are my next plan. Even if I'm taking a special session, if I'm taking a YouTube session, I always update it on the channel. And these days I'm also trying to upload some interesting MCQs which I come across while preparing my lectures. So that is like you can be in good touch with pediatrics while you are studying some other subjects also. It can be a good practice session. Not many MCQs, but some atypical MCQs that I come across and I feel is something good and interesting to share with all of you. Okay, so I end my session over here and catch you back tomorrow at 7:30 with some serious topics. Okay, take care and stay safe. Bye bye.